You can start.
Oh, and I did not hear a beep.
Go ahead. No problem.
Okay. Thank you very much for the kind introduction. I really appreciate this opportunity to share what my team and many others in the field have learned about our topic today, social connection and support as targets for youth suicide prevention. And I'm going to take our time and share a number of previous studies in the field, recent but previous, and then some of our work as a program, our Youth Depression and Suicide Prevention Research Program. Briefly, a disclosure. And let's move to the topic. What do we mean by connectedness? This is a word that's getting has much more visibility in our field than it once did. We used to talk about social support, perceived support, social engagement, social integration. And now it's largely the sense of belonging, being cared for, feel supported, feeling a connection with other people. School, family, and non-family adult connections have all been linked with more positive youth outcomes. So let's just step back a bit and look at where we stand with youth mental health in the US and some of our national prevalence data. And what I'd like to share today, because it's relatively recent, is the ABES, the Adolescent Behavior and Experiences Survey, that the CDC developed and implemented to look at student behaviors and experiences during the pandemic. So this was conducted across a 6-month period in 2021. It is similar to the YRBS, but it was a different survey developed specifically for this COVID period. But similarly, they surveyed a nationally representative sample of students, high school students, from public and private schools. It was anonymous, it was online, and as you can see, about 8,000 students submitted surveys. And just to hit some of the highlights of what we learned with this, is you can take a look at the right, at the percentage of high school students who shared that they felt sad or hopeless, seriously considered attempting suicide, actually attempted suicide, had a suicide attempt that was medically treated, and who said their mental health was most of the time or always not good. And the percentages are on the right together with the confidence intervals. So these are some distressing data. But to get a bit more and closer to our theme today of connectedness, you can see the third item here that I've bolded and put in a larger font. They strongly agree or just agree that they felt close to people at their school. This was only about half of students, somewhat slightly less than half of students felt close to people at their school. So in addition to the mental health concerns, clearly there's a problem with belongingness, and for many of these individuals, school may have been hybrid at this time. We know that suicide is a leading cause of death among adolescents in the United States. Some of the early data from 2022 suggests that more than 6,500 young people ages 10 to 24 died by suicide. We also know that males account for the majority of adolescent suicides. When we talk about youth or adolescent suicide prevention and preventive intervention strategies that we implement during the adolescent years, I think it's helpful to keep this figure in mind. As we can see, the x-axis, the horizontal axis here, is going from ages 10 to 25. And what we can see is the increase in the rate of suicide across this 15-year period. And as we can see, there are suicides, and every single one is a tragedy among pre-adolescents or pre-teens, tweens. But we also see how the slope increases more during these teen years, and you start to see this bigger divide between males and females. So when we're intervening here with adolescents, say ages 12 to 17, we are both trying to prevent suicides during this age range, and we're trying to alter the developmental trajectories of these young people to prevent suicides during early adulthood and middle age years, because many times the risk factors are cumulative, and in a developmental transactional model, risk can be exacerbating another risk over time, almost like blowing oxygen on a fire. So the earlier we believe, the further upstream we get involved to prevent suicide is a better opportunity to prevent it in the near term and as development continues. And just for perspective, I wanted to share the international worldwide data. This was put out by our World Health Organization, the State of the World's Children in 2021. And I think we so often look at our US data, this was actually put out by UNICEF, that we don't often consider the worldwide perspective. And one thing you can see here is where suicide falls for our teenagers ages 15 to 19 across the world. So it is still a leading cause of death, number 4, road injury as number 1 worldwide, and unfortunately, tuberculosis, which I know many people are working very hard to address across the world, is a major killer of young people still. All right, let's look at some of the national calls to action. We certainly have the U.S. Surgeon General's advisory, Protecting Youth Mental Health, Ring the Alarm, the Crisis of Black Youth Suicide in America. These major calls to action both came out within the last 4 years. And as part of the U.S. Surgeon General's advisory, they know, really with an evidence base that we will talk about shortly, that one of the steps that family members and caregivers can take, and I think that we can take as mental health professionals, is to help youth develop strong, safe, stable relationships with youth and with other supportive adults. So let's look at the risk factors centering in on social connectedness, rejection, isolation. I think this group is well aware that suicide risk is highly heterogeneous, that 2 youth at risk for suicide may have very different combinations of risk factors. And that's why we work hard with clinical judgments and risk formulations and comprehensive assessments of both more stable risk factors that we can't change now, like a history of trauma, being a male. These are not things we're going to work with clinically or with preventive strategies necessarily after the fact, although we have effective treatments for trauma history. And then some of the warning signs and more acute risk factors. And low social connectedness is certainly one of these that we believe is modifiable. So let's look at a systematic meta-analysis that was published a number of years ago. And here they looked at the associations between school connectedness and suicidal thoughts and behaviors among students in grades 6 to 12. And they looked at a variety of moderators of the effect sizes: race, ethnicity, gender, the type of connectedness measure. They really had 16 study samples that they considered in their meta-analysis. And what they found in this was that higher school connectedness across different school connectedness measures that were used in these 16 studies was consistently associated with lower suicidal thoughts and behaviors. It was also associated with lower thoughts and behaviors related to suicide for general, broad populations of students, students who were high risk for one reason or another, and sexual minority students. This protectiveness of school connectedness was consistent for both suicidal ideation and attempts, and it varied across samples. That it was stable across samples that varied in the percentage of white and percentage of female sex at birth samples. Now let's look at another study published in Pediatrics several years ago. This is from the National Longitudinal Study of Adolescent to Adult Health. They looked at the long-term protective role of connectedness across multiple health outcomes. They were not specifically looking at suicide outcomes, but all of the outcomes that connectedness may have a role in protecting against negative outcomes for young people. This was a nationally representative sample, began with students in grades 7 to 12, and then they were looking at longer-term outcomes in adulthood. And in their multivariable analyses, they had a large enough sample to do this. They found that school connectedness was protective in reducing suicidal thoughts, physical violence, victimization, multiple sexual partners, sexually transmitted disease, drug misuse. And family connectedness also had a number of protective qualities for negative outcomes. And they actually developed a kind of an infographic, which I think sometimes is helpful in seeing the findings more clearly. And their findings are really here in the middle. That adults with strong connections at youth were much less likely to have a variety of negative health outcomes. And that's one thing that's really important to keep in mind when we think about preventive strategies and interventions, specifically for youth we consider to be at risk for suicide, perhaps because they have one risk factor or they have multiple. But these youth, as we've learned, are certainly at risk for a variety of other outcomes that can be harmful to their development into and beyond adulthood. So this would be risky drug use, risky sexual behaviors, unemployment, engagement in violence. These are overlapping pathways. Many risk factors are similar and overlapping for these various outcomes, so that when we are implementing connectedness type strategies, perhaps we're focusing on measuring suicide related outcomes, but we can certainly consider expanding that, because we would expect to have positive benefits if it's an effective strategy on a variety of negative outcomes. All right, let's look at the challenge of predicting adolescent suicide attempts. You know, a relatively low frequency behavior, although happening more often, certainly with more youth than we would like. I think many people may be familiar with the meta-analysis conducted by Franklin and colleagues and published in 2017. It's really an elegant comprehensive meta-analysis looking at many different moderators of how risk factors do in predicting suicide-related outcomes. The challenge is that the data that were available to them, they were only able to look at single risk factors, one risk factor at a time. And of course, in clinical settings, people have not thought that single risk factors do well for as long as I have been involved with clinical practice. It has always been a risk formulation where we're taking into account multiple risk factors. So I think we would say those findings are not surprising, And I actually think in another 20 or 50 years, single risk factors will not do well either, because we really need, with suicide risk, to consider the multiple facets of risk and how they're coming together in time. Now, many clinicians emphasize suicidal ideation. It certainly doesn't capture all adolescents at risk, but we do believe, although we've rarely had large enough studies to look at risk from a multivariable perspective, that they have the potential and can improve risk recognition. So I want to share some of our recent findings from a very large multi-site national trial that was funded by the National Institute of Mental Health. This was called ED-STARS, the Emergency Department Screening for Teens at Risk for Suicide. This was funded to develop a new screening tool, which we're not talking about today, which was the CASI, the Computerized Adaptive Screen for Suicidal Youth. But because we were working with a large national network, PCARN, the Pediatric Emergency Care Applied Research Network, that has separate federal funding for research infrastructure to do large-scale studies in pediatric emergency departments, we were able to obtain a very large sample that was geographically diverse. I wouldn't say nationally representative, but geographically quite diverse in the United States. And because of the large sample, we could look at a multivariable way at predictors of suicidal behavior 3 months after the emergency department visit, both univariate predictors, single predictors, and then considering all predictors together. So I mentioned this was multi-site, 14, and then the second study was with 15 pediatric emergency departments. We also involved a public health service, Indian hospital, and did universal screening in the emergency department, meaning this was all youth who were able to complete a self-report, regardless of the reason for the emergency department visit. So it could have been a mental health or suicide-related concern. It could have been a high fever associated with influenza or COVID. It could have been a problem with a non-adherent diabetic regimen. It could have been a sports injury. It could have been a traffic accident. So we screened all youth who came in ages 12 to 17 years. We administered a very large suicide risk survey. Now, this is partly because we were developing a computerized adaptive screen. We needed a large bank of items to develop the algorithms for that screen, which could take into account different combinations of risk for suicide attempt through its algorithms, so that the screen was adaptive. And after the teen answered the first few questions, the further questions depended on their response to the earlier ones. And that's what is meant by computerized adaptive. But to develop those algorithms, we started with a large survey with all, based on the extant literature, all the known risk factors for teen suicide attempts that could be important in the short term. So it's a very large list. Some of them are here, and you'll see more on the next page with our findings. We were funded to measure outcomes with telephone interviews of parents and youth for a subsample of those youth. We did this with 2,900 youth. We did randomly identify more youth with more risk at baseline, a higher proportion of those, higher proportion with moderate, but some with low risk, because we needed the full continuum for prediction and for developing the computerized algorithm. We enriched it for moderate and high risk because we also needed enough suicide-related outcomes to be able to do this. But our primary outcome was suicide attempts. So we looked at the multivariate prediction, and here's to start with just looking univariate. So every clinical risk factor based on the extant literature that we included in our survey at baseline was a univariate predictor of who made a suicide attempt in this sample. And here are some of the items. None of these are probably a surprise to our group. Non-suicidal self-injury, both the number of methods and the number of incidents, recent suicidal ideation, depression, alcohol use, cannabis use, thoughts of self-harm, duration, sex, assigned at birth, sexual minority identity, gender minority identity, and all of these clinical predictors were significant at the univariate level, not necessarily individually, counting for a great deal of variance, which is consistent with the Franklin meta-analysis. Then, because of our large sample, we were able to put it together in a multivariate model. And I think what's interesting is that 4 items remained as significant in this model. The first 3 are suicide-related. Recent suicidal ideation, the lifetime severity of suicidal ideation, and the lifetime history of suicidal behavior. Now, thinking of the first 2, why do we probably need both? It's often been shown with adults too that the worst point suicidal ideation is important. We find with many youth, this also happens when you're querying about alcohol and drug use. That day when we're asking them, they do not report ideation. That could be for any of many reasons. They're concerned about what people's reactions might be. They're ashamed. Last time they shared it, they had a bad experience and they were hospitalized. They don't want that to happen again. They're actually not, they're having a good day and they're not having suicidal thoughts. And yet they will report more severe thoughts previously. And that seems to be important. Similar when we're asking about alcohol and drug use, we sometimes have individuals who say, no, that's not, they report very low. And then when you ask the last time, it was a week ago Saturday that they had a big binge of alcohol use. So it seems to be important. Those are accounting for unique variants. But the first 3 are all suicide related. And I think many of those other univariate predictors were upstream of these 3. They were psychiatric symptoms like sleep disturbance, hopelessness, anxiety, depression. They were many things leading to one of these 3. And then we have school connectedness, which is a different domain that we're capturing, an interpersonal domain. We could replace school connectedness in this model with social connectedness. They're somewhat overlapping. It's just a touch less powerful. They don't go in there together, but it's clearly the 4th item is a connectedness item. And let me share what these scales were, because they're fairly simple. This is how we measured school connectedness, which turned out to be that powerful in a multivariable model. Now, I think as psychologists, at least in my training, we often emphasize the use of longer scales. They may have better psychometric properties in some ways. But when we're working in an emergency department and trying to do a survey with all the extant risk factors, we work very, very hard to have shorter scales. And of course, learned as perhaps epidemiologists have known for quite some time that these can work well too. A little bit how science actually happens. The study had 3 PIs. I was doing this study with David Brent, a child psychiatrist in Pittsburgh, and with Jackie Grubb-Phelan, a pediatric emergency physician who at the time was in Cincinnati. And what we did was get out Google and a map to see what would be the midpoint of those 2 sites in Ann Arbor. We ended up finalizing the survey and the length of scales, trying to find subscales whenever possible, looking for factor analyses, looking for strong items. In Mansfield, Ohio, spending an entire day together in a conference room to pound out what items would be on our final scale. Now, let me also show you the social connectedness scale. Again, very short and useful, may be useful clinically, could certainly be useful in further research. All right. All right, let's look at changes in social connectedness and outcomes following hospitalization. This was a study led by my colleague, Eva Sis, who conceptualized, designed it, and carried it out. And what she was looking at was if post-hospitalization changes in connectedness with family peers and non-family adults predicted suicide attempts, the severity of ideation and depression across 12 months following the hospitalization. This study sample was 338 psychiatrically hospitalized suicidal teens. It was a longitudinal 12-month study. And the two key findings were that improvements in peer connectedness following the hospitalization in that initial period, a lower likelihood of suicide attempts across 12 months, and improvements in family connectedness, less severe depression across 12 months. So what can we do? Just a sampling of possible next steps and maybe some ideas for further research, as well as telling you about one intervention that we've developed and where that is now. I mean, the CDC has a number of recommendations for schools to promote connectedness. Some of these have more research than others, but they're all consistent with existing research findings. Sources of strength, Peter Wyman's work out of Rochester. This is a school-wide universal suicide prevention program where it prepares peer leaders to build protective influences to try to change norms and behaviors. They model and encourage the people in their networks to engage trusted adults, to increase communication with adults, the idea that adults are there to help us, using some of the coping resources in the school. And the evaluation they conducted with 18 high schools from 3 states with a random assignment at the school level to the training versus the wait list. And they looked at the impact on the peer leaders and at the norms and beliefs in the entire student population. First, look at the impact on the peer leaders. They actually changed their expectancies of adult helpfulness. They did reject codes of silence. There were a number of positive impacts on them. And for the student population, the perception of adult help was improved for peer students with ideation, and the acceptability, the norms for help seeking for adults. So I think some very positive changes in terms of school norms, the idea of a connection between the students and the adults in the school, and the availability of support. Now, I'd like to turn and tell you about our youth-nominated support team intervention. This is based in social support and health behavior theories. It's a psychoeducational social support intervention. The initial development and piloting was supported by Ronald McDonald House Charities, and the first clinical effectiveness efficacy trial was supported by NIMH. These health behavior models have been had been used already for decades in other areas of healthcare with chronic illnesses, heart disease, diabetes, asthma, where you're looking at how others in the network can be helpful to the person, what they can manage on their own, what are their beliefs about treatment. So there's a different perspective on it than treating the symptoms. It's getting to a broader model of ways to improve individuals' support and health behaviors, the choices that they're making. And in YST, there's certain key components. One is that the adolescents nominate caring adults. So we're working to empower adolescents. They're nominating the adults they want to be part of their support team. This is something I developed with a team when I was working on the adolescent psychiatric inpatient unit, and had a consistent experience that we were discharging adolescents from the hospital, and many times the parents were overwhelmed. They were waiting for an outpatient appointment. They experienced fear about their youth safety. Hospitalizations were getting shorter and shorter. They were really for stabilization and evaluation, and not so much for treatment, except for the treatment of the structure and safety of an inpatient unit for a short period of time. And so the idea was, what can we do as a transition from inpatient to outpatient to put a network around this family to help them with the transition? Now, since then, it's being used in other ways. It certainly could be helpful to youth who aren't transitioning out of the hospital. But the idea is that the adolescents nominate adults they feel they trust, that could be helpful to them, that they can talk with, that they perhaps would like to have more involved in their lives. The parents have veto power. They almost always approve. The adolescents know the parents will need to approve. They are nominating these adults from all domains of their life. So the staff are facilitating the nominations. Many times a suicidal teen's first response is there's nobody. But with facilitation, we have them consider up to one parent who lives in the home with them or caregiver, their extended family. We had many aunts, uncles, grandparents, older adult siblings and cousins. The school, it could be a coach, a club leader, theater, a music teacher. It could be the counselor from the school. Certainly people from the community. We had youth group leaders. We had a rabbi. We've had a minister. We've had a whole variety of people involved as caring adults. And they nominate up to 4. And on average, you can see in our trial, over 3 support people consented and came to our orientation and training education session for support persons. So the first part of this, the YST model, is the youth nominating these adults. The second part is that this intervention is designed to be adjunctive to our more usual treatments that are focused on just the youth or the youth in their immediate family, such as psychotherapy and medication. It wasn't designed to be a standalone intervention, rather an adjunctive intervention. We bring these adults in. The intervention is not with the youth, it's with the nominated team of adults. They learn with the parent and youth's permission about what the youth is dealing with, what the treatment plan is, how they can be helpful to the teen, how to talk and listen with the teen. They generally have that down. The youth has nominated them as someone they can talk with. And we support them with weekly check-ins, these nominated adults, for 3 months. They're encouraged themselves to have meaningful contact with the youth, however they define that, on at least a weekly basis. And some of our findings. So what is the role of the support people? One thing I want to emphasize is it was not to be a mental health professional. We were very clear with that. It was to be a caring adult. We encouraged them to offer emotional support, being there, to encourage ongoing treatment adherence with recommended treatments, and whenever it was possible, when the youth brought something up, to lean in on the side of positive behavioral choices. This was a large clinical trial. Sometimes now it's almost hard to believe that we took this on and conducted this trial, but we enrolled 448 acutely suicidal adolescents from 2 psychiatric hospitals. This was done about 20 years ago. These were all teens who were hospitalized for acute suicide risk. And they were assigned to YST or usual care. So it would be usual care plus YST versus usual care only. So it's not an active add-on to the comparison group. We used a computerized balanced allocation strategy. This was at 2 hospitals. Within hospitals, we're balancing on younger, older adolescent, whether or not there was a history of multiple suicide attempts, and the sex assigned at birth. And the findings were very modest at 12 months. We had a more rapid decrease in suicidal ideation for the YST group, but that quickly leveled out. What we did find is the YST group did, in keeping with what we would anticipate given the role of the support people, they did participate in significantly more treatment across the first year. That was true for psychotherapy, medication follow-up appointments, and recommended drug treatment. There was no effect at 12 months on suicide attempts, or certainly on suicide. And then as a team, we looked again, we realized we had such a large, well-characterized sample of acutely suicidal teens. The team involved felt very positively that they were making a difference with so many families through their involvement in check-ins. And at both the orientation session with adult support people and the check-ins, it's tailored to the youth's issues and treatment plan and to the support person's needs. So it's very much based on inviting their questions and responding to them and sharing tailored resources with each support person. So there were some core resources about child and adolescent mental health, how we think about it, about depression and its treatment, about suicide warning signs and what to do. There were some core things. But other resources might be, you've learned that they're being bullied. How can you talk with them about it and respond? They're going through bereavement of a grandparent. What can you say? And they would ask for a whole variety of resources, and we would tailor it to their needs. Then with the team support, and I want to especially thank a team member, Ale Arango, who took a big role in coding the National Death Index data. We obtained this data 11 to 14 years later. We had sufficient records to do this. We used the CDC published criteria for how to code it. Two staff blind to the intervention status. Neither of them were part of the study when we originally conducted it. Evaluated all the records the CDC sent us, and then we confirmed the deaths with state death certificates. Now, this is a sad part for our team, because we did meet with the youth in this study, both in the hospital and in person. That's how we were doing research more at the time. We didn't have the virtual option. We met them in person at 3 months, 6 months, and 12 months after the hospitalization. 15 of these young people had died 11 to 14 years later. We confirmed all of them with state death certificates. They all died in the state of Michigan, where I am at the time of the study. And there were 13 deaths in the treatment as usual group and 2 deaths in the YST group. Now, the hazard ratio looks very large, but we really are most interested in the confidence interval, which you can see it's a wide interval because it's a small study for a mortality outcome study. It's possible to get more extreme findings in smaller studies. And although we're looking at over 400, the many of our mortality outcome studies in healthcare might be thousands. They tend to not be in mental health. We probably need more large-scale studies. I don't know of another one in the adolescent suicide risk field, and this is relatively large, but it's not tens of thousands. So if you look at the confidence interval and the low level of it, the 1.5 would suggest about a 50% reduction in deaths. This was all-cause mortality. We also looked separately for deaths that were only due to suicide or drug overdose, so self-injury mortality. Now, the drug overdose had to be unknown intent for this analysis. We didn't count drug overdoses. About a percentage of them are considered accidental, unintentional, and then some of them are unknown intent. If it was called unintentional accidental, we didn't include it in this analysis. So this is suicide and unknown intent, and that was 8 deaths versus 1 death. So very promising data. And if you can take a look at some of the characteristics of our 2 groups at baseline, when I first sent this in, this was published in JAMA Psychiatry, and when I first sent it in for publication, it was interesting. After it was published, the editor contacted me and he said, I've received a letter to the editor that I'm thinking of publishing. How might you respond to this? And it was someone wondering, well, they match on all these things, but maybe there were more multiple suicide attempters that were males, meaning a higher risk. And I wrote back, I actually have that data. And it's just interesting when we're trying to interpret these data, how many things you can look at to try to get at what's going on. Because we randomized to the 2 groups, as you're all aware, generally they're going to balance on factors. However, when a factor is really important and could drive the findings, that's why we use the balance allocation, which we did use for history of multiple suicide attempts. But what you can see on this one is the ages, of course, were very similar, the percent female, single suicide attempt history. These things were very, very similar. And then I can show you the next slide, which was what we looked at after we got the query. Were there more boys who were multiple suicide attempters in the TAU treatment as usual group? And we pulled these data out, and as you can see, there was no difference here in the number of boys who were multiple suicide attempters. This graph, and it's important to see here, I'm starting at 0.80. This is a survival probability. And I did it this way. I think it's also this way in the publication so that you can actually see each tick down was a person, teen, young adult, who died by suicide in the study. And this is our YST group, and this is our other group. Now, just to think about that a bit, why might that be? And people have asked me, of course, we wonder, is it a fluke? I would love it if someone would replicate this someday. This won't be me, but I would invite someone to replicate it. But I think the reason, because we offered weekly support to these support people, either individually or as a group. We let that flex based on their schedules and what they wanted to do. Sometimes teachers had a very narrow window. We did our weekly check-ins with them separately. Sometimes aunt and grandma wanted to meet together. Sometimes we had the whole team together. But we offered them support and additional resources as needed, these 3+ adults, every week for 12 weeks. And that's short. But I think the way it may have had an ongoing impact is that most of these adults were already in the teens' lives. Unlike us, when we come in and offer a short-term treatment and then we go away, they're in their life and they're staying in their lives. There's some exceptions. perhaps a teacher who's only doing it for the period of time. But most youth had support people who continue in their lives. And what they did by nominating them, many of the adults were taken with that, like learning that the youth wanted them more involved in their life. And the youth let them in closer. So did the family, the parent. They shared with them what was going on. Many of them did not know what was going on. They didn't know what the treatments were. They didn't understand the treatments. They didn't have a sense of how to be helpful without support. Some of them worried without support that they'd say the wrong thing or make it worse. So I think the ongoing role of these adults in their life and being brought in closer, hearing from the youth they want them more involved, may have made a difference across time. Now, just to share another idea that I would love to see someone do research on sometime. I know this is going on in some places in my state, and they may or may not be conducting program evaluations. I think it's a great idea when we look at the importance of school connectedness. And what they do with what is called invisible mentoring is you bring all the staff in the school together in a room, and you have the names, let's say this is a middle school, of all the students on the wall, on the boards. And you ask each staff member to go up and circle the names of all the students they know. And then what they find is there will be a handful or more of students in the school that not a single staff member said they knew. And the goal here is to reach out and connect with these students who are, in a sense, invisible students in the school. This is one of so many ideas of what we might be able to do with connectedness with our youth. I think the key is to get beyond thinking that the entire story is the treatment of the most at risk. I think probably this group is well aware of that we'll always need that. We'll always need emergency care and safety plans, intensive treatment, hospitalization, perhaps for those most at risk, but that we want to go further upstream and work with some of these people in ways that are in naturalistic settings, that are comfortable, non-stigmatizing, maybe involve entire schools or involve them with their own support team, which is culturally tailored because they're choosing the adults from their communities to take part. And think about how we can develop and evaluate the effectiveness of preventive strategies at different levels, and try to identify some that are as non-stigmatizing and as effective as possible. I'd like to acknowledge so many people. I mean, I shared a couple, our work with YST across the years, our work with ED Stars, a couple of our larger studies that have taken place over the years. These are large teams. And also the members of our Youth Depression and Suicide Prevention Research Program, a very synergistic, collaborative group of people that has contributed in many ways. Bottom line is that connectedness matters. I believe it's a worthy target for our preventive and intervention strategies, not only for suicide prevention, but for the prevention of a range of negative health and social personal outcomes in early adulthood. Thank you very much. I invite you to contact me at kingca@umich.edu.